All right, good afternoon, everybody. Today, we wanted to review a little bit about SATB2-Associated Syndrome, also known as glass syndrome. So this is fairly broad, and many of you are familiar with the information I'm about to present. So I apologize if it's a little redundant. I'm trying to keep it as friendly and general as possible with a few updates here and there for everybody. All right, very good. Well, just to get started, so here's my outline of how this is going to go through. So first, we're going to review the timeline on how the syndrome was diagnosed and where we're at right now. Then we're going to talk about what it is and how common is SATB2-Associated Syndrome, which we will abbreviate it as SAS. And then we're going to talk about why did it happen and what are the chances that this could happen again. We're going to review the main features of SAS. We're going to be talking a little bit about the different ways that you can get SAS, and part of that is going to be talking about if there are any differences between the different ways that you can get SAS. And the last couple of things, we're going to review some of the guidelines as far as management and general recommendations for care. And we're going to end with the sort of outline of the research on my side, at least, on the immediate and near-term future. And then a couple of words on the registry. All right, so with that said, the first part I wanted to review was the timeline. So SAS has been described for a long time. To be more precise, the first individual that was diagnosed was in 1989. And this individual had a deletion, which is, again, a piece missing in chromosome 2. So again, that was, 30 years ago. And really, the gene was discovered later, in 2003. That's when we first learned that this gene was important for craniofacial, face, palate, teeth kind of development. And this is the reference where that came from. And really, it took even a few more years, 2007 to be more precise, when the actual first individual with a mutation, which again is the type of change within the SATB2 gene, was described. So that was in 2007. This was an adult male in his 30s. And then a few years later, we figured out that there was other ways that you can get this syndrome, including, again, those that have pieces missing, even smaller than this first case. So that was reported a few years later, and really it took 7 years from the first individual for the second individual to be described, which you see her picture here, and that was again in 2014. And then in between those years, there was a lot of understanding and learning that happened in different studies looking at how the gene works and whatnot in mice, and we learned a lot about what the gene does for development of the face and teeth and the palate through a variety of studies. All right, and then we go to the last few years, and this is when I got involved. I got involved in 2014 when we figured out that there was many more individuals that had been described. We started collecting them, and then we got that report out in 2014, and then Dr. Fish and I reviewed what was known at that point for all the cases that had been previously reported. And then since then, we've done a variety of studies looking at bone issues, and then we had a fairly comprehensive look at what happens over time. That was 2018, and then More recently this year, we completed the work on speech and behavior, and there's other things that we've done here and there as far as dental and other things. So, and then in parallel, we've been able to, make improvements in several other areas, not just describing what happens, but we got the registry started in 2016, and then we had the initial website launch soon after. We were able to get the syndrome added to the list of rare diseases by the NIH officially in 2017. We had the first large meeting here in Little Rock, 2017, and then the nonprofit came in 2018. We had our second family meeting in 2018. That was another international meeting. And then just recently, this past summer, we had the first dedicated clinic, not just as part of the family meeting, but just as a SATB2 clinic by our team this past summer. It went pretty well, and that's kind of where we are at the moment. So allow me to now continue with what is SAS and how common is it. So what we do know is that it's a rare genetic disorder. As I was mentioning, it is caused by alterations of the SATB2 gene. The SATB2 gene is located in chromosome 2. And we don't know exactly how common is it, but we have a sense in general of how common it might be. Again, there's no right or wrong, but if I was to guess, we did figure out a few years back that looking at all the samples that a reference lab did for individuals that had undiagnosed intellectual disability or developmental delay, a fraction of them, again less than 1%, 0.24 to 0.3%, had a mutation in this gene. So that's the tricky part, that I don't know exactly what to use as how common undiagnosed intellectual disability is in the general population. But if we were to use an estimate of around 1% in the general population of undiagnosed individuals, you multiply that by this 0.24 to 0.3, then you get the 1 in 30,000 or so. Again, rough estimate, which for genetic terms is relatively common. There are many other genetic conditions that are around that number that we're very familiar with. So I think that we're ballpark pretty close to be accurate with this estimation. All right, and then as far as the registry goes, which that's another way to kind of get a sense of how common is it. As of today, so I was updating the numbers this morning, we have 162 individuals that have completed enrollment in the registry and done the online database part of the collection of information. And then I know about 50 plus that have reached out to us at different stages and, my kid has SAS and how do we go about it? But we couldn't get them enrolled or paperwork was not completed. And then we have those that have been previously reported that are not included in the registry that I know about. And I keep an eye on new publications that are coming out on a regular basis. So if you were to add that, I got about 285. Now, I'm aware that the support family Facebook group has hundreds of members, and that's the part that I don't know how many have had legit confirmation of the diagnosis and how many are caregivers versus actual individuals with this. Roughly, again, those are the numbers I have, about 285s at the moment. So as far as the demographics, the registry actually is pretty nice in the way that I can, click a couple buttons, and at least for the 160, that are currently enrolled, I can, look and see what the distribution is. There's a slight male predominance, not probably anything statistically significant. But then you look at the current age breakdown, which is part of the limitation that we have, because we know the bulk of the patients are in this 0 to 10 range. There are many others, yes, between 10 and 20, but then you see the sparsity after 20. And I know one of the things that a family wanted me to discuss today was related to the adults, how they present and whatnot. And honestly, it's been hard simply because there's not enough numbers. So I have a lot of individual, mostly anecdotal reports, like, oh, my son or daughter, adult, presented with this or that, or had this problem or that. But we haven't really compiled that information, which it is on my list of things to do, as you will see later. All right. Next, we're going to talk about why did it happen, and could this possibly happen again? So we do know that, like most genetic syndromes, we really don't know why it happens. So not that I've really been trying to collect information about, how old the mom was or the dad was, or exposures. We haven't really looked at that. But for the most part, and this is true for most genetic syndromes, we don't know why it happens. Now, in general, in genetics, we know that there might be an effect on the chances of having new mutations in the sperm, mostly when the sperm ages. But that I couldn't tell you if that's the case here or not. So, and in most instances, there's only one person in the family affected, and that's what we call de novo. If you look at genetic testing results that you may have received on your significant other or child, you will see the word de novo frequently mentioned. So that means that it's just brand new on the child. It cannot be found, the mutation or the misspelling could not be found on either parent. So in most instances, that is correct. It happens only in one person affected in the family. But, there's always a but, it has been documented to happen in more than one sibling on a few occasions. And that has led us to estimate or provide 1 to 2% recurrence risk. And I'm aware of several families, again, that this has happened, but in with different types of mutations and ways that you can get SATB2. So I've seen it with those that have misspellings within the gene. I've seen it for those that have pieces missing. I've seen it for those that have extra pieces. So it can happen throughout, really, in a variety of different ways. Now, most of the time, I would say, when the child is tested, has he or she goes through genetic testing, a lot of times the mom and dad samples are collected at the same time. So, and this is where the de novo part of it comes, when the results of the genetic testing are available. So most of the time, again, if you look for the misspelling or for the piece missing or extra in the mom or dad, you're not going to find it. So negative parental blood testing is, it's a good thing. So it probably reduces your chances that this could happen again, but it does not rule it out. And that's always important to keep in mind, because you're only testing the blood. So granted, there's been, actually, I'm aware of a few instances where the given misspelling that the child has was found on the blood sample of mom or dad at a very, very low level, which he will probably explain why there may have been multiple siblings affected. But that's the exception to the rule. It can happen, but that hardly ever happens. So if mom and dad had their blood work done and it was negative, again, that's reduces the chances, yes, but it does not completely rule it out, because you're only testing the blood. The only way to know for sure is to test the sperm or the egg, which is really not common or feasible test in regular practice to go test sperm or eggs for that matter. So this is what we call mosaicism, which you cannot rule out completely based on a negative blood test. So just keep that in mind. All right, so and then when we go through the genetics part of it, so the SATB2 gene, or really any other gene, they all produce a protein, and the protein has a given function. That's true for any of the 20,000 genes in our body. The SATB2 gene is no exception. It produces SATB2 protein, and we know the SATB2 protein has many functions, and it's what we call a transcription factor regulator, which means that it controls the function of many other genes in our bodies. So that's part of the tricky situation, because it has so many functions that it's hard to completely fix the problem when it has so many functions and so many other genes that it controls. So looking at chromosome 2 here, this area Q33.1, just highlighted here, this is where the SATB2 gene is. If you were to zoom in closely, then that's where you get the SATB2 gene. And this is sort of the cartoon representation of the SATB2 protein, which again is the product of the SATB2 gene. So the protein has 733 building blocks. You know, I get a lot of questions about what does the genetic test result mean and whatnot, and it's always important to remember that it is a long protein, 733 amino acids, and when you look at genetic testing results, it's going to tell you a lot of times where the problem is. Sometimes it's in the beginning, sometimes it's in the middle, sometimes it's in the end. But that's kind of just to give you an idea of where the problem might be located. So how do you get this syndrome? There's really, for simplicity purposes, 4 different ways that you can get it. So you can have mutations or misspellings inside the gene, and you will see words like missense, frameshift, splice site, nonsense. So that typically you have a letter replaced by another letter, or perhaps 1 or 2 letters missing, or 1 or 2 letters extra, that, you know, fool our body into how it's supposed to be read, the genetic code, and basically results in this protein being, you know, terminated before the 733 position. So you have a block or ending, you know, here or here at some point in many instances, at least when it comes to frameshift, splice, and nonsense. Missense, again, you have a letter for a letter, so the protein is the same length, but it does not function well as far as we understand it. So that's one way you can get it. Second way you can get it is you can have a small deletion. That means that you're missing a bunch of letters, not just 1 or 2 letters. And the letters are normally grouped into what we call exons, so you can miss 1 exon or multiple exons. The SATB2 gene has 12 exons. The third way you can get it is you can have an even larger piece missing. So you're now missing not just a chunk of the gene, but you're missing the whole gene plus other genes around it. I'll show you a figure of how that is. And then the last way that you can get it, oh, actually I got this backwards. So this is for extra pieces, duplication. Same idea, you have an extra piece in chromosome 2 that involves this gene, or again, you can have deletion, which is a piece missing that includes all of the SATB2 gene. So when we collect data, and this is why I ask, you share the genetic testing results with me first, just to see that I'm talking about the same thing, because there's been some occasions where families have reached out to me and like, hey, my kid was diagnosed with this, but it's not really the same thing because this gene is not affected or is not included within the genetic change that the child may have. So, but part of it is that, and then the other thing is that you can start mapping it and, locate all the given misspellings that somebody may have and then compare, right? So I get asked often like, hey, has anybody had the same misspelling that my child has, and this is how I can tell. So, you can map it and, put it along the drawing of the 733 building blocks here. And you can see the number represent the number of individuals that have been reported with the given misspelling. This is the most common misspelling, this R389C. At least 10 individuals have had it. But anyway, so you can kind of get a sense of how often some changes happen and the different types of mutations as well. And then this is, you can do the same for what we call the intragenic deletions, which again is when you have now a chunk of SATB2 material missing. I mentioned before that you have this, we call exons. You have 12 exons. So you can have, just one exon missing, like here, or you can have a couple, or you can have, 8 or 10, but not the whole gene, right? So that's the next mechanism. So you have chunks of the gene missing, but not necessarily the whole gene. For practical purposes, this is going to result in the same, which is one of the copies of the SATB2 protein is going to be non-functional or doesn't work. All right, and then you can go and look at the ones that have the SATB2 gene missing, which you see it here, circle, along with many other genes. And the red bars are for those that have deletions or pieces missing. The blue bars are those that have duplications or extra pieces. But you can see, right, so it all depends how many genes are missing. So, this individual 72, for example, is missing a bunch of genes, not just the SATB2 gene, but all these genes are missing, which, might create additional difficulties. And that's part of what we're still in the process of trying to understand how that changes. So I've done the work of collecting all this information, and this same graphic is actually on the SATB2gene.com website. So you can kind of compile it all and see, break it down into what are the most common ways that you can get it. Again, the large deletions, if we add this up to 19%, small deletions, again, if you have just one exon, which again are those 12 boxes within the gene, or multiple exons, another 12%. And then the most common type of mutation is what we call missense, which you see here, about 25%, and then you have the other types of mutations. So you kind of get an idea of, or the breakdown of how this happens. All right, we go to the next point, which is related to the main features. So you all are aware of the main features, what we call cardinal features. And these percentages are primarily for those that have what we call intragenic changes, so those that have mutations within the gene or pieces missing within the gene. So basically everybody but those that have really large pieces missing or extra, which those numbers are somewhat similar. I just have not had enough numbers to kind of compare apples to apples yet, but it is on my list of things to do, as you will see later. So the cardinal features, just remember, speech is significantly affected pretty much for everybody. The abnormalities of the palate, primarily with cleft palate, but you can have bifid uvula or high palate. Teeth anomalies are fairly universal, as we have learned, and there's some things that can be seen on the outside, some things that x-rays will show. Behavioral abnormalities, again, 75-80%, very common in general. The other part are the other B's, I guess, here, and the acronym. So bone issues, which there's an asterisk here because not everybody has gone through bone density scan. So the ones that have gone through bone density scan often are abnormal, and that's the 71% here. And then there's brain abnormalities primarily detected on brain MRI, which again, not everybody goes through brain MRI. And then we do know that happens in the first 2 years of life, and you see the acronym that we came up with a few years back just to summarize the main features, which still to this day are accurate. There are, of course, many other things that we learn over time that can happen. These include excessive drooling, for example, feeding issues, This can happen with or without a cleft palate. Those that have cleft palate, of course, have more mechanical issues, but we've seen that there's other feeding problems, not just appetite, but sometimes putting too much food in their mouth, or sometimes chewing. Low muscle tone as well can happen about 60% of the time. Growth retardation also has been seen, and just as an observation, and I've evaluated a lot of individuals, and really they all tend to have the same kind of body build, kind of thin and tall sort of situation. So there might be more to the story, and again, another area of research that I'm interested in looking at in the not distant future. Lazy eye, also called strabismus, about a third of the time. We do know that about 20% of kids have seizures, and this is something that I'm actively working on. We do also know that the EEG, which is electroencephalogram, can be abnormal even without having seizures. So when they go through the EEGs, often they have abnormal electrical activity of the brain, but not enough to be called a seizure or something that, as we know that a seizure is. So it's not correlated on the outside with, staring or with, grand mal, what we call, full body checking is not correlated with that, but there's electrical activity that sometimes is abnormal. So we've seen that, and often it requires the study to be done on a prolonged period of time, not just a 1 hour EEG, but sometimes an overnight stay or longer to reflect the abnormalities. All right, so in the past, we've collected a lot of data. We put up a couple of graphics looking at the natural history. So, we've collected, through the registry, we have compilation of when kids start walking and whatnot, which evidently most kids start walking a little bit later, but almost all of them at some point start walking. It's just when more than if. But the same cannot be said about speech, which we've seen, variability for the most part. So there are some that do start saying their first word when we would have anticipated, which is around 12 months. But, there's some that even 4 or 5 years of age, they still haven't said their first word per se. So that's one way to look at the data. We've also looked at the data in different ways as far as what is the current total level of speech, which again, we know is the main area of development that is affected. So I would say, the majority will have either, no verbal communication or a limited amount of words. And there's, and I have met these individuals myself. I know that there are some that are much more verbal than others. And to be honest, we haven't really been able to tell why that is and what determines who gets to speak more. Is not a function of age necessarily, as you see here. There's some older individuals that are still struggling to communicate. So I'm not sure, but again, I've met many of these individuals that are more verbal, and we're still trying to understand what can be done to get to this level up here. As far as the behavior, again, very common. There's a really broad spectrum, and I heard all kind of behavioral issues in the past. For the most part, they still describe as very friendly, but often alternating with episodes of frustration and tantrums, and mostly related when they have difficulties communicating. And this is something that I've heard multiple times now, that for some reason going through puberty and early adulthood seems to, I don't know if it's hormones or whatnot, but seems to trigger a lot of aggressive tendencies. And again, as we explore the clinical part and what happens as individuals age, we might be able to get a better sense of how this happened and when it happens and what was done to help these children. And there's a well-known problem with sleep. It can be different ways: difficulties falling asleep, staying asleep, waking up multiple times during the night, restless, etc., etc. As far as the bone issues, we do know that the bone density is common, often related to a low vitamin D. There's a marker in the blood that we use that is called alkaline phosphatase that sometimes gets elevated. But the good news is that even when we documented that the bone density is low, it does not correlate significantly, I would say, with having excess fractures. So the bone density often is found to be low, but does not necessarily mean, okay, this child is going to be having fractures within this amount of time or whatnot. So we do like to get the bone density and get an idea where we are, and then maximize the vitamin D part of it, calcium, to try to minimize the risk for fractures. But again, thankfully, even though the bone density often is found to be low, thankfully it's just only the minority of the individuals that have recurrent fractures that need more aggressive interventions. All right, the fifth topic here relates to the differences between the different ways that you get SAS. So we've looked at this, and again, as we compile more data and the numbers increase, we might be able to answer some questions. So the bottom line is that there's really no major differences that we've seen, at least when it comes to changes within the gene, or even pieces missing within the gene. The one thing, a couple of things I was going to mention here is that for missense mutations, it appears that cleft palate happens less often, but seizures do appear to happen more often in the same group. And then likewise, we've looked at, okay, when do they start talking, depending on what type of mutation and how many are nonverbal after age 4. It appears that the proportion of nonverbal after age 4 is higher for missense compared to the other groups as well. But you can see that the numbers, again, are small in some instances, which makes comparisons harder. This is something we've done before, looking at what happens when you have what we call a large deletion, meaning the SATB2 gene is missing with a bunch of other genes. And really, what we've seen is that growth tends to be more of a problem in this group, but we really could not tell that there were any other major differences in the past. Now, it's exactly the same problem as we had before, which is we didn't have enough numbers. But as I'll tell you, in the process of now, I think we have enough numbers now, basically, to continue the research in that area. All right, we go through the care guidelines. I get asked very frequently, treatment and intervention. So as a starting point, there's no specific medication that we would use that has been proven for SAS that it will fix the problem. Now, that doesn't mean that nothing could be done. It just means that we target our efforts at this point mostly to treat the symptoms and preventing things from happening, but there's no medication that we would recommend at this point universally for all kids with SAS that with the intention to cure or fix the problem. So that's kind of where we are. Not that it wouldn't be, it's just it hasn't been found yet. So we have developed care guidelines that are available on Gene Reviews, which is a public website, or you'll find it on the SATB2Gene.com website as well. And the foundation website, I think, has the different cheat sheets with some of the recommendations that we've put out in the past. But in general, it's very self-explanatory. You go system by system and try to address all the problems one by one. The one thing that's not in here that I did want to mention, I do routinely recommend a DEXA scan, a bone density scan, around 5 years of age. We do that with an alkaline phosphatase, and we do that with a vitamin D, just kind of see where we are with the bones. And depending on that level, then it might need to be repeated in the future. And then more recently, we're trying to understand, do everybody need an MRI or not? Which the short answer is it appears that you don't need an MRI unless you have seizures or something else, especially if you already know the diagnosis of SAS. And then seizures, that's the tricky part, because, of course, if you're suspecting seizures, you would do it, and just having a low yield of ordering the EEG, meaning if you're somewhat suspicious, seizures can happen in this condition, or more reason to get the EEG. But we're seeing that there can be so subtle, and the electrical activity in the brain can be abnormal very frequently, especially during sleep. So it's something that we're actively looking at. So we'll be able to hopefully put out some recommendations in the near future as far as, what type of EEG needs to be done and when to do it. So we're looking at, when can seizures present, when was the age and diagnosis for most individuals, what was the latest it can happen. So we're trying to answer those questions. When is there an age where, you're free, you won't have them, or, your chances are much lower. So we're looking at that as well. So stay tuned for that. And then as far as the therapies, especially when it comes to speech and dental care, we have put out those provider recommendations and letters on the SATB2 Gene website. So feel free to consult there. All right. So, and then the last part is just talking a little bit about the research plan. I've shown this slide before to some of the families. It's always important to understand, because it's always the conception like, okay, well, what are you trying to do to fix the problem? Which is always an ongoing discussion, but the first thing is always got to be trying to understand what happens, because if you don't know what happens, then you don't know what you're trying to fix. So that always has been phase one of SAS, at least for me, and I know Dr. Fish, trying to understand what happens. So as you know, I do the clinical part of it, and then there's a parallel side, which is what happens, with the cells or the mice, what happens in the gene, but all with the same intention, which is to advance to the next part of it, which is trying to find, once you have an understanding of what happens, then you can start trying to fix the problem. And, you can compare the before and after. If you have a baseline of what the abnormality is, then you won't know if a drug helped or not, basically, when you're trying to do testing on cells and whatnot. So, and then that eventually, hopefully, will lead to us identifying something that can be used in actual individuals. So the registry part of it, which is hosted here by me, is aimed to looking at this side of the equation, and then on this side, for the cells and the gene level, we collect samples, and we have done that over the years, trying to understand what happens with the same intention. So as far as actively happening that I'm aware of, at least on my side, on the clinical side, so we had the mutation update paper. This is actually a slide that I used a few months back, so happy to update it at this point. So the mutation update, it really is a comprehensive review that just came out a couple of months ago, looking at all the individuals with mutations in this gene, not the deletions. I kept them separately for a future project, again, waiting for more numbers to happen. But that just came out not long ago. We finished our speech paper we finish our behavioral paper, at least a starting point. Actively working on brain MRI and seizures. Many of you may have received a link from me or asking for help because I identified your child as having seizures, so we're actively working on that. And then on the laboratory and research, so we call bench research side of things, we're actively, let's say we as in me and Dr. Fish, looking at what happens in neurons. So we have neurons that you can actually artificially generate a SATB2 mutation, and you can kind of see what happens there, which actually is a very nice setup to see what happens. So we're looking at that. And then on my side, so Dr. Fish is doing this number one part. My side, we actually have been looking at what happens with metabolism and sources of energy. We got 5 samples in the past, got some preliminary results, and we put our application for funding through the foundation, and I was lucky enough to get funded for that. So that would allow us to complete the work with 6 additional samples. So stay tuned for that. I'm hoping the next 6 months to a year to have that completed. And now these are upcoming, so they're all in my queue of things that I want to look at. I'm going to look at deletions. Again, that means pieces missing, large. I think that we're at a point where we have enough numbers. So that is on my list of things to do. I want to look at growth. And again, adults, I have a good idea what's going on, but I'm in the process of looking at that. So it's going to take me some time just to develop the type of questions that I would want a parent of an adult with SAS to answer, considering some of the things that families would want to know. But I started the process. I have a student working with me on that, so stay tuned for that as well. And then we have collected good dental information, of course, in the first 2 years of the international clinic, and then recently when we hosted the summer clinic, some of the kids went to the operating room and we got impressions and other things done. So that might allow us to keep working on the dental part of it. All right, and then more recently, you all have probably heard about the stem cell research part of it. So the idea would be to look again at what happens once you have changes within the SATB2 gene and then start testing some compounds, some drugs. So Dr. Fish is helping me with that. So we got some samples, skin samples in the past that we have sent to her lab. And those will be used to create stem cells. So we are in the process, as you all know, of raising the funds to do this part. Once this is done, we have funding to run some experiments related to the function of the gene and drug testing. We just don't have the funding to create the stem cells. And the samples are from one individual with a nonsense mutation, and an individual with an intragenic deletion, and an individual with the most common type of missense mutation. So this covers, I think, the vast majority of SAS cases. All right, and then the last couple of slides, I wanted to talk about the registry. So as you know, I host the registry. Katie Bosanko, which is my genetic counselor, she helps me a lot with this part as well. So the idea behind the registry is that we collect as much data as we can in a variety of areas. So not just demographics, but genetic testing, medical information for all types of different mutations and whatnot. And really, the registry is what we've used to publish all our work so far. So it is a very useful thing to do. So myself and Katie again take the effort there. So some of the questions that you will see are related to age, gender, age and diagnosis, that kind of stuff, genetic testing results. We have birth measurements, medical history, other studies that may have been done on the individual. So as I finish here, I do want to ask for help when it comes to the registry. Definitely it's helpful, you know, and I try to put it back and give back to you guys all the results as we compile them. I'm always happy to, you know, if you have a specific question or like, oh, you know, what's the oldest individual that is in the registry, or, you know, this type of mutation or that, have you had anybody? It's easy to consult the registry. So it's not a one-way, you know, street as far as sharing the information. I'm happy to provide it back, and as we, you know, compile the data for our papers and whatnot, and of course I route them to the foundation and they make them available to you guys. But it is very helpful to participate, so I will encourage you to do so if you haven't. But with that, I think that's all I had. Hopefully this is helpful, and thank you all for the opportunity to share my thoughts. Well, thanks so much.